Hello, everyone. Thank you for joining us today. I'm Jenny from Education Team at Medic. Nice to meet everyone. And we have Dr. Hector here.
Hi, how you doing today?
I'm doing great. It has been a while.
Yeah, a few months we mentioned before.
Yeah.
Yeah, but I'm glad we're back. I'm glad we're back, and we are going to be recording and doing some other webinars. I'm very excited about it.
Yeah, so today's topic is really exciting. I'm really fond of the topic about occlusion, implant occlusion. So can you talk a little bit about it?
Yeah, well, it's a bit different compared to teeth occlusion. We're going to see in this lecture is 45 minutes, where we're going to cover how the implant occlusion is affecting your mouth because it's a slightly different to teeth occlusion. And we're going to share you some little details and tricks on how to deal with implant occlusion.
Yeah, I think the occlusion is key part when it comes to the longevity of implant crown, right?
Yeah, especially when we're talking about long term. If we don't want to have problems in implant, we probably should be checking the occlusion.
Yeah, so shall we get started, doctor?
Yeah, I think people are going to enjoy this one.
Yeah, sure.
Yeah. Right. Today we're going to be talking about implant occlusion. Occlusion itself is a big topic, and not many people look into understanding occlusion. Well, it gets a bit trickier when we talk about implant occlusion itself, especially if we're starting to place implant or we are just doing the surgical part. It is important to understand that occlusion, those implants, they're going to be in occlusion. They're going to have restorations on top. They're going to have bridges. They're going to have full arches. And we need to think about that occlusion to make sure that in the long term we don't have problems. So we're going to try and give some light to this topic. We're going to try and master that implant occlusion. I know in 45 minutes it's not going to give us the whole picture, but maybe we'll have some insight of what the implant occlusion could be. You surely have seen implant failures. You may or may not have seen them yet, but this is a case of mine where the implant crown fractures. So implant failures, you can see them from screws, screw fractures to screw loosening. Sometimes you can see the whole screw head breaking or just half of the screw going. The main issue with this kind of failures is when the screw is still down there and there's only a tiny portion that's left. If the screw head breaks at the very top, like this one here, we probably can retrieve that. But if this one breaks at this part here, it's probably going to be a bigger issue. Also, when you have some abutments, a screw, when you have a abutment in the middle and the screw breaks on top, like multi-unit or other intermediate abutments, that's probably not the biggest issue because we can always replace the intermediate abutment. But still, those fractures do happen, and we're going to try and understand why this happens. Then you might also have seen, these are not my pictures, but you might have seen porcelain chipping or zirconia fractures. Those are probably due to occlusion as well, so we're going to see those. You may have seen these as well, where the whole full arches resin that they break and they come apart, or if it's porcelain, metal and porcelain fused to metal, you may see those fracturing as well, or chipping. You may see some of the porcelain coming out. And then this case is mine, where you have a zirconia, where you have a metal frame and you have zirconia, milled zirconia on top. Well, those ones, we need to make sure that we do them correctly. And I'll show you why this one broke in there. One of the main issues that can happen here is cementation. If this is not properly cemented to the top one, then you may have a small gap, and then zirconia is not flexible at all and it can't break. But then that gives us a bit of headache when you see these kind of cases and you're like, what have I done wrong? I thought my implant restorations were fine, and then they start breaking or coming loose. So as we said, the screws, if they break here, you probably won't have a problem removing them. But then what about this one? What about this one here, where when the screw is up there? Or sometimes when not only the screws break, but we have implant failures. And then that case is mine as well. When you see the implant head is fractured, and you look at the patient, and the patient comes with the crown that's loose, and you're like, oh my god, the whole crown is loose, and I can't really scrape back in because this rotates on itself. So implant failures can come from many parts. I mean, you can have just the head that's broken. You may have half of the implant is gone. You can also have a vertical fractures to the very end of the implant, and they come with some bone loss. But these cases, they're not as difficult to treat, because at the end of the day, the implant, nearly half of the implant, more than 60% of the implant, is not covered by bone anymore, because you get secondary perimplantitis on those implants. The problem probably is these kind of implants, they're fully integrated, they break, and then you need to retrieve them. So a case like this one, where you have to drill out that implant, because you can't really unscrew it. If you try to place any sort of abutment up here and try to unscrew it with a negative torque, you're probably going to keep breaking the implant, because you can't really hold to anything. It keep breaking. So we need to drill the implant out of the bone, and you probably don't want to remove any bone, or at least not removing much bone. So you end up having to drill a lot of titanium. You use a lot of burrs to make sure you don't heat up the bone, and you end up with massive defects like this one. We'll see how we can deal with those in probably another webinar, but definitely when you got this kind of situation, you probably want to avoid this, and you don't want to have the patient having to come back to place another implant 3 to 6 months later, because you can't really place an implant here. So if we introduce the implant occlusion, the most important part is, why does occlusion matter? Why are we doing this? Well, you've seen failures can happen, and we want to prevent them as much as possible. So screw loosening is something that happens quite often. But if we see fractures, we probably don't want to just replace the screw or replace the abutment and off you go. Because if that broke, there must be a reason. And if there is a reason, we want to find the reason, not just fix the problem and then send the patient away, because that's probably going to break again. And this time you may have a screw that just loosened, or just the top of the head is broken, and then you replace it because you are able to retrieve that implant screw. But if you replace it and then you end up breaking the screw at the very end, then sometimes you need to either use a shorter screw or you need to remove the implant. And that's the last thing that we want, especially on very healthy implants where there's no problem, no apparent problem in those implants. You want to keep them as long as possible. You don't want the patient to have a surgery just for that. And then also occlusion matters, and that's also related to teeth. It does prevent problems, muscle problems, joint issues, TMD problems. Well, obviously prevent bone loss. If we want to prevent bone loss, if we have an implant and that implant breaks, then you're going to have bone issues like we just saw. But if you have an unbalanced bite, you might have muscle issues, you might have headaches, you might have joint problems. So it's just not only just to prevent them from breaking, you want to give the best case scenario for the patient regarding, say, you have to do a full mouth regeneration, you have to do a full mouth rehabilitation, and and you have to place 6, 8 implants, and you need to do a new arch. You need to think about those things before you just place them, and then you give them a smile. They're happy with the smile, but they can't really bite onto anything. So that's why it does matter, and we need to look at those things. Then, what's the ideal occlusion? Well, we need to see and understand the difference between teeth and implant. Teeth and implant are not the same. They're very similar, and on the outside you can sometimes trick, even dentists, they're tricked to see which one is the implant, which one is the tooth. But when we're talking about biology, they're completely different things, especially when we have a missing periodontal ligament, and we're going to see those things. Then, when does it matter? Well, every single time that an implant is in contact with another tooth or another implant. If we have an implant that's just supporting a denture, then it doesn't really matter if occlusion it's there or not. But if it's opposing another implant or a tooth or dentures, sometimes you can get away with it, but especially when you have something hard to bite onto, we need to look at those things. So the core concepts, and you're going to see a lot of references down in the presentation because I've taken other authors to just kind of back up my research. And the main difference here, and we know this, is the mobility that we have on teeth due to the periodontal ligament. It goes from 25 to 100 microns, micrometers. So you have movement, and every single time you're biting onto something, that tooth moves ups and down. If you have a top tooth and a lower tooth, you add up those two, they can go up to 200 microns into the bone, where an implant can only come from 3 to 5 microns. So we're talking about 20 times less. And there is a lack of proprioception, so you can't really feel that you're biting. It's been said that you can feel the whole bone, biting against another jaw, but you don't have that proprioception. So you may overload those implants, and sometimes, especially in full arch, they end up biting way harder than with natural teeth. And then the load distribution is going to be completely different because periodontal ligament, you have all the forces spreading throughout the ligament like a cushion. Where in implants, I think it was 90% of the load goes in the first third. So this study is really good because it shows where the first third of the implant is being loaded. So that's where if we ever get fracture, is going to be here. It's probably not going to be at the very end of the implant because the loads are here. So if we talk about implant protected occlusion, we need to think about the implants as a structure that's fixed, and we need to load them in the axial axis. So in this graph, these implants are loaded lateral to the axial force. If we ever place the load in the middle, then look at how the forces are spread through the implant. They're not as damaging as these ones. They're not as hard as this one. They dissipate quite better. But not only that, they get even better while we have narrowed occlusal plates like this one. So this one is wide, but also the cost inclination is high, steep, where this one is a narrow occlusal table. And then this one here is a narrow occlusal table with very flat cost tips. So this is the scenario that we want to have on implants. So when you got lab designing your implant restoration, they're probably going to do this kind of situations because they're imitating teeth. Well, implants are not teeth. So we cannot really place or do this kind of restorations. We probably need to think about something a bit more like this. Maybe not that as exaggerated, but maybe a bit more like that. And we want to avoid any lateral or non-axial focuses. We're going to see why in the presentation. We're talking about something about more like this. So what are the challenges we're going to find in implant occlusions? And this is the core of the presentations. We're going to see all the overloading factors. We're going to talk about parafunction habits. We're going to talk about the cantilevers and how the distribution of those cantilevers can affect to the load on the implants. And then the implant design. And that the bone quality also has a role in this, but not as much. And then the clinical consequences, what really is going to affect us as clinicians is going to be the prosthetic failures, like we've seen already, the marginal bone loss that we may have, and then how we're going to deal with that, and the adjustment that we might have to do in those implant crowns. So we talk about parafunction. First thing of the challenges that we might encounter, clenching and grinding. We do really need to have equal intensity contacts in your whole mouth. This is some those on principles. Posterior inclusions in harmony with the envelope of function. You probably have seen this diagram. That's something that we're aiming for. Obviously, if we're only placing one implant crown, then we may need to think about, should we first deal with the occlusion and then place that implant crown? Or can I just place that implant crown there and hope for the best? So it's more about the whole principles than just having to place one single implant. And then we need to really be careful about the first point of contact, the posterior interferences, and then if we have any steep guidances. And we're going to see them through the presentations as well. If we ever get the first point of contact, I have a nice case to show you at the very end. So this patient here had the first point of contact in an implant crown. So I mounted those models after this patient lost this, the whole implant came loose. And then we checked this in an articulator. This is plaster. So I digitalized the models, but then this was plaster. When I did this and I checked the first point of contact, you can see the first point of contact was in that implant. Then on posterior interferences, this is the same case. I'm going to see it at the end, where you have a right or left lateralities and you end up catching on an implant crown. This is not the case because this is a wisdom tooth. But imagine that this scenario was here and that was a 7, that was an implant. Every single time that patient goes to that laterality, you end up catching on that tooth. So we really want to avoid these kind of scenarios. And then steep guidances. So we have another case like this one here. Apparently doesn't look too bad. This tooth bridge. So this is a tooth, that's another 2 teeth, and that's a cantilever. So these 2 teeth were all splintered, those 3, with this as a cantilever. And then he came into the practice with this deep bite. And then, if I want to place an implant here, what's the occlusion going to be? Because if he managed to break a zirconia bridge in half that was cemented to teeth, and those teeth had a bit of a movement between them, but you end up breaking them. If I place something that's rock solid like an implant, and the patient has the same deep bite, then we might need to rethink about the treatment, or we might need to help him with that curvus P and try and level this arch and the lower arch. So those are little things that we need to think about. And then if we go into the cantilevers, the rule that we need to think is to try and avoid them as much as possible. If we cannot avoid them, this is from Mitch, all the principles with the cantilevers. This is something that we want to avoid, especially if we're doing a canine here and the guides are all here. So the implant position that we need to, or we probably want to have, is at the very beginning and at the very end, so the terminal parts of them. So this is a class 1 lever. And then we've got magnification of the forces. Everything we apply forces here is going to be multiplied in this area here. So especially if we have power function or if we have reduced crown height. Like here. So if we apply the force here, that's going to go way higher up in here and in this area here. So this is what we want to have, something a bit more like this. And then the force direction is important as well, because we have high risk of crystal bone loss. The buccal bone thickness needs to be minimum 1.5 because of a lot of principles, but one of them is also because of the load. And because the total force is increased, we have higher risk of porcelain fractures and then abutments or screws. If we apply some forces, instead of applying them completely axial to the tooth, we apply them lateral. We may have 100 newtons here, but we end up with 118 newtons at the very end because of the lateral forces. If we apply this to an implant, on an axial one, we have 100 and then that's it. Where if we apply higher loads in a tilted implant, we end up with 50 on a buccal and then 86 on an axial. So you need to add those up. So you get a magnification of the forces. So we want to really try and avoid these kind of scenarios. Then if we go into the implant design, really important, the implant design here. This is another study done by Dittmer. And then he was seeing how the implant design can affect, because if we have a connection, like the conical connection here, that's going to be spreading the forces through the implant, where here, like an external or an internal connection that just goes in the very first millimeter, the forces, they're going to be spread completely different. So the load bearing capacity of those implants is different, and we need to know these kind of cases. If we place conical connections, we may have more advantages, not only because of the load distribution, but also due to platform switching and other things that are there and out there, and we know they work and we know they preserve bone. And then the thickness of the implant as well. If we have very thin implants, they're very likely to break. If we have a 5 millimeter implant with a 3.4 platform, then we do have enough implant structure to hold the forces, and the implant probably won't break. But then we need to think about if we're using a very thin screw or a very thick screw, like multi-units, they have a very 1.2 millimeter screws, where if you go to different system, you may have 1.6, 1.8 implant diameters, so they're less likely to break. And then the critical walls, when we talk about critical walls, Elias was talking about how in this area here, that's where you get the fractures. This is a external connection, and you only have 0.42 in the system that he was studying, where in this one you may have different thicknesses, but the forces, the loads are completely separated. They are more well distributed compared to this one, where the load always goes to this area. Prosthetic failure, we talk about them, screw loosening, normally due to lateral forces, fractures, abutment fractures, prosthetic fractures as well. You may have porcelain chip, zirconia fractures in bridges and crowns, and then implant fractures. They're rare, but obviously they're catastrophic. If the implant comes out, the implant fractures, then the whole implant needs to come out. So those influence, if the implant is thicker, we know less likely, and then the critical one, we just mentioned that. So we do, and we can have marginal bone loss, and then this study done by Di Fiore, he was talking about the occlusal overload can lead to bone resorption, other factors as well, like biological factors, perimplantitis, plaque, the implant design, the placement on the implant, if the implant is out of the bone or not. We obviously have a lot more factors, but occlusal overload is a big factor to marginal bone loss. And then we can adjust and we can prevent these kind of scenarios if we adjust the bite on those implants. But we need to think about how to adjust the bite, because I've seen so many just drilling it out. And then if you have a tooth on the opposing arch, then that extrudes itself, and then you end up having that contact again. So it's not just about drilling, it's knowing where the forces are and how to deal with it. We need to monitor those changes because teeth move but implants don't. Then Marion, in a case in a study, he found out that just adjusting the occlusion in an implant, you can recover the bone that you lost. So it's important to know that occlusal overload is there, and we don't want to have any bone loss in those implants. If we get to the solutions and how to deal with those things, so first thing is to share the forces throughout the system, so throughout the whole mouth, if we can. If we have two implants, and I mean, if we have a bridge, we obviously need to splint the implants together. But if we have two implants, like a 6, an upper 6 and an upper 7, and those two implants are in a very soft bone or they are in a sinus elevation, that's just bone that's artificial, that has been placed before to elevate the sinus flow, we probably want to splint those implants. And not sure why people don't like to splint implants, where they work quite well if we leave enough space for the implant to for the patient to clean the area. I would splint the implants. I haven't found any study that said that's better, but if we have an implant that you're unsure that you have enough stability in the long term, secondary osteodegradation, and that implant is in a regenerated bone, you probably want to splint those implants. Also, you want to reduce the load in any angle implants, as we said, because you're going to have magnification of that load. And we want to reduce all the lateral forces in those implants. There are going to be some exceptions, and we're going to see them. But try and avoid them as much as possible. Then we want to be placing splints, even if obviously if we have a full arch, we want to protect our work, doing some night guard or at least something to protect what we've done. And if we have just one tooth that's completely healthy, then probably we don't need a splint. But if we have a patient that has perfunction, that has bruxism, that has wear in his teeth, then we probably need to think about splints. Then the very end, if we can, I'll recommend to go to do guided surgery, because we want to have the ideal implant position. If we have that implant that's completely buccally placed, then the implant not only aesthetically can be a problem, not only biology can be a problem, but also the loads on that implant are going to be way higher. So we want to make sure that we reduce those loads as much as possible. If we place them with a guided surgery, I'll show you at the very end as well how that can improve in these scenarios. So the occlusion and how to design it in different scenarios. So a full arch prosthesis, we want to have a group function. We're going to try and have not only the canine guidance. If we only get canine guidance in a full arch, you can end up with some chipping, especially if we have implants against implants, because every single force, all the load, they're going to go into that canine, and at the very end, that tip of the implant can fracture. That can fracture, that can chip, and if it's zirconia, sometimes you see fractures, vertical fractures that go into these canines. So we're going to have group function. Group function is canine and maybe both premolars to that side, but nothing else in the rest. That's completely different if we do an ovidentist. I think ovidentist, we probably need to think more like a balanced occlusion, like having nearly every single tooth touching when we go into the side. Like in dentures, we want to preserve them and keep them, especially if we have resolved bridges, where you place those 2 or 3 implants with locators, and you end up having them to replace the little plastic on the locators every few weeks, and they're all worn down. That's probably because of the occlusion as well. So we want to make sure that's balanced, and you don't need those implants to leave the denture in place. That's probably the aiming that we're trying to do. Also, in single tooth restorations, we need to minimize the forces and avoid lateral guidances. The only exception is going to be, well, obviously we have a canine, that's an implant. We want to have group function in the rest because that implant is not going to bear all the force in just one implant. If we have two central, we probably want to spread them through the centrals and the laterals. And if we have just all the anteriors only, then we probably want to have as much as we can completely spread throughout them and not only in one spot on right in the middle. Reduce the cantilevers, as we said, they're not going to help us. If we can reduce them as much as possible, and if not, just reduce them in length. Sometimes we don't need a full molar as a 6, full 6. We can have a premolar 6 as the size of a premolar. It doesn't need to be 12 millimeters, but maybe just 8 millimeters, 6 millimeters premolar at the very end work. And then we need to do the periodic reevaluation and occlusal adjustment of those implants. So if we talk about splints, I've talked in a few webinars already, so you can go and check them out, how to do splints and how to deliver splints. I'm not gonna get into much detail with splints. If you wanna know a bit more, they're there. And then to guide the surgery, so these studies that I found is, can we really place an implant in the position that we planned if we do it freehand? So the study shows that we can't really. Most of the times we won't be able to place it exactly what we want. So the precise placement to have the optimal occlusal outcome is needed. So there is a study that also shows that static computed aided, so the one that you go and it's live, is the one that gives you the most precision. But really, if we have a guide, even if we partially guide them, not with all the burrs, but maybe just have the first one to have the depth and the angulation, the plant position is going to be nearly the same, and we're probably not going to get any big discrepancies. So at the very least, I'll say, get yourself a guide to have just the first guide, the first burr, to have the depth, to have the direction, to have the angulation, and you're probably good to go. So I'm going to try and illustrate everything in one case. I think it's a nice case to show because it has a bit of everything. So this case is Hector. He's got generalized wear, and he's got some parafunction. He does clench, he does grind. He's 58 years old, and he's been doing that for many years. He was wearing splints at night, but through the day he was still clenching, he was still grinding. And then he had an implant placed. I didn't place that implant 5 years back, 5 years before I did anything. I saw him. So the implant is there. Doesn't seem to have any trouble so far. He was doing okay. You have a zirconia crown on top of the implant, but also you have a zirconia crown on top of the arch. So zirconia against zirconia, who wins? Which material is going to fracture first? Because in most cases you have natural dentition on top, and then you end up with zirconia against natural dentition. You end up wearing down that natural dentition. Where here, maybe this one will suffer more than the others. So this was his case when I first scanned him. And you see, well, there's no major problems. I mean, the bite is spread through the system. There's not really major issues. But then if you think about the case, and one thing that did happen was he came in with the whole crown and the whole implant in his hand. What happened? The whole implant, there was no bleeding in the implant. There was no bleeding on problem when I checked. It was fine. Nothing really happened to that implant. But you see, the whole thing came out, and it wasn't even sore. He could take it out. So for some reason, there was an occlusal overload in that implant, and I wanted to check why. So he had the models of, well, that's what the implant was. And you can see the wear there as well. so probably because of zirconia on top. But then he had the plaster models with him, so I was able just to screw back the implant crown that he had back where he had the analog in here. So screw it back in. I mean, I unscrew from the implant, I screw it in the model. And then I took some bite records in a stable condylar position where I could have a better understanding of what was going on. And I could check that the first point of contact before he could even close his mouth was in this implant. So I said, look, this could be an implant overload. Let's rethink about the whole thing, because I'm not going to be plating an implant again. And then in 5 years, you're going to have the same problem, because I can leave that crown a bit lower. I mean, not as high. But then can you see how this crown here, this tooth, has already extruded? So this is higher up compared to this one. With this one, the upper left 6 is extruded. So if I leave this one lower, then the other one is going to extrude, and then we're going to have the same situation down the line. So we did some ortho on him, upper and lower ortho. This is just for you to see how we wanted to intrude these teeth. I wanted to intrude that one. We wanted to intrude back those in place. And this is after the ortho. So now he had some stops in the back. This is a really big anterior open bite. But once I remove those stops, we can end up with a situation that we could restore. So we did a full mouth rehabilitation. I'm not going to go into details with this. We did veneers, crowns. Those are veneers. I mean, he had a composite veneer in this one on a kind of conical tooth. So this one is more like a 3/4 crown. It's not a crown because it doesn't go over. But this is a veneer. Those are 3/4 veneers as well, because it's covering palatal. I did some simple composite work here. That's just the lab work, which is great. They did an amazing job. And we cemented first the anterior, then the posteriors. We do this in stages. We've been doing this for a while, so I could get into detail in another webinar maybe about full mouth rehabilitation. But then this is where I could place another implant. I guided that new implant. I don't have the pictures for that, but I guided that new implant. I waited because we were, I think it was up to a year with the ortho. So the bone was fully healed, and then we could place a new implant in a different position, slightly different position, to get as much natural bone as we could. And then that's the implant crown. I mean, it's a completely different implant crown than the one that he had. The good thing about this case is not only I've been able to restore the whole function in his mouth, but only then I'm placing the implant, and only then this is a temporary one. If you see the different color, this is a temporary. And he stayed with the temporary for 6 months after we'd done everything. So in a case like his, he had a right lateral canine guidance, then you have the left lateral canine guidance, and then you have the picture where you have the anterior protrusion, and then you have posterior disclusion while he's doing this. He's a bit class 2, and you can see the midline is off because he's more class 2 in this side than this side. But then we are able to deliver the final zirconia crown to a titanium base. That's what I normally do. And then how Medi helps us in this is after we've done the whole case and after the place, this is only in the temporary. And I'm sure that I can place the final one here. Is after they've done an occlusion analysis with the occlusion analyzer. So in this situation, we can ask the patient to open and close and have some scenario where we see how the bite is. And if the bite is not too heavy in that implant crown, it is important to see if it's not heavier than in others. Then we go into protrusive, and we see how the patient does the left lateral with the canine guidance. And then we got the right lateralities. And you can see the right lateralities is doing it with the left, with the incisal, because of the class 2. This canine is further back. So we can see it from an occlusion point of view, where here we don't have excessive bites. And if you see, and if I go back maybe a little bit, 1 second. When he's chewing here, this one is higher up. It goes a bit greener compared to this one because implants, they don't move. So I want them to be slightly in infraocclusion, slightly only. This helps us massively to see. So you have the right laterality as well. And if you remember at the very beginning of the presentation, I was showing how the right laterality sometimes can be catching somewhere. And this helps us to see if we have anything catching somewhere, and we'll be able to adjust it. So great tool, helps us massively in these cases, and we see how the implant occlusion here is perfect. So what's the benefits of using MEDIC to check the occlusion? Well, we have improved accuracy and efficiency. So articulating paper works and has been working for decades probably. But we will have a mark in an implant and we have a mark in a tooth. Which one is heavier? So there is a lot of systems out there, like T-scan. You got also the Bosch one. There is another one as well. So they do a great job knowing exactly how much force you have. But it's another tool, it's another gadget that you need to buy. Where here, if you also already have a MEDIC intraoral scanner, you can see those things. It might not be as precise, but it can give you a really good understanding of what's going on. And also it does help with the patient communication, because we can tell the patient, can you see, well, why is this happening? Why is this screw coming loose? Why is this crown breaking? Well, you scan them, you ask them to do some lateralities, you ask them to chew, and you see how they overload probably that implant crown, that implant restoration. So it's a visual aid for the patient, and they do commit with treatment because you see they see some red and then they're like, oh, I don't want that. How do I solve this? Well, we need to restore the canine guidance in this side for me to fix this. How do you restore them then? That needs veneers, crowns, or whatever it is. So it does help with patient communication. So intraoral scanners, you have them, but then the future of occlusion here with implants and with teeth, the principles are the same, and we need to think about the patient as a whole, and not just I'm placing an implant and not affecting the occlusion. Well, you are. The patient has lost a tooth because of something. Maybe it was because of a cavity. Maybe it was just because that cavity became a root canal, and then the root canal fractured, and then the crown on top of it, you have a vertical fracture, or you have, very commonly, you do tend to have these patients where they just starting to have a bit of pain, and then you root canal the tooth, and then you extract the tooth, and then you place the implant, and then you lose the implant, and you end up going back. Maybe it was just an occlusion from the very beginning. So prevention is a major issue here, major thing that we can do, and monitoring the patient to avoid any problems. I mean, you're probably not going to see the problems in the near future. And I have a sentence here that AI helped me find it. Occlusion is a silent factor that determines the success or failure in the long term. So we're probably not going to see it immediately, but it's always going to be there, and they're going to determine if that implant is going to last many years, just 5 years, like the patient that I showed you before. So these problems can be solved. The AI integration in those things, the program that I just showed you, the occlusion analyzer, there is a lot to be developed still. virtual articulators and seeing exactly, like, tracking devices, jaw tracking devices, and seeing exactly how the patient bites in a normal food that he's having. It's probably the next steps for this, and we're getting there, and we're seeing and understanding the virtual patient very well. So I think probably the next steps is going to be those. Thank you so much for your attention. I hope you enjoyed it. I know it's not a topic that many people like to talk about, or many people want to hear about implant occlusion. If we ever get a fracture, how to solve it. We could look into how to deal with those things afterwards as well. If you have any questions, please don't hesitate to send me an email. That's my socials. You can look up for the Instagram or my website. Anything, I'm here to help. Thank you.
Okay, thank you for sharing your tips. So let's move on to Q&A sessions.
Yeah, thank you very much. I hope you enjoyed it.
I really enjoyed a lot. I'm really waiting for the Q&A session as well.
Mm.
So we have 4 questions in total. So I will start with the first one.
Yeah, that's perfect.
Question number 1. How do you approach occlusal adjustments in patients with existing TMJ issues?
Well, that's a very broad question, and we're going to try and resolve it together. So first thing that we need to make sure is that the patient has healthy joints. If obviously the patient doesn't have those healthy joints, then we probably need to deal with them before we try and even thinking about placing implant, especially when we have a patient that's a bruxer, or we have a patient with a lot of wear, or maybe this patient has headaches or muscle problems. We probably need to deal with those issues before that. We have another webinar. I think we talked about splints. Splints is a very good solution with those kind of TMD patients. So to answer your question, ideally, I'll be saying, please first fix the patient's joints problems or muscle problems, and then you'll be able to place the implant a bit more relaxed, because you're always going to be stressed if the patient has any other issues that not in just your teeth, but in your joints, in your muscles, or sometimes in your gums as well. We're very used to dealing with patients' gums before we place implants, but we're not dealing with joints, so we probably need to deal with those beforehand.
So you check patient's condition with cross wear or any different method?
So on your first consultation, you should be checking for those things. You should be having a really thorough consultation where you check exactly what's the patient situation, what's the patient needs. And then obviously if the patient has a gap, if the patient wants an implant, then we'll deal about that. But probably in a later stage, not at the very first thing.
Okay. So next question. Question number 2. How do you create occlusal table in implant crown? Is it going to be any difference from the natural teeth?
Yeah, I think we mentioned that in the lecture. So most of the time, lab technicians, when we ask them to make a crown, an implant crown, they tend to create with the same software as a tooth crown. Implant crowns, they have to be slightly different to teeth crown. So they have to have a smaller occlusal table, and they cannot be as steep when we talk about, especially in the molars and premolar area. So they need to have a smaller table and to be slightly shorter in terms of the cos tips. Why is this? Because we want to avoid any lateral forces in those implants. If we get those lateral forces, that's when we can get either screw loosening, or we can get a fracture in the crown or in a screw, or that's the worst case scenario will be an implant fracture, and we don't want those. So definitely trying to adjust the design to avoid any further problems.
Minimizing the lateral force is the key part. That's what you're saying,
Exactly.
right?
Yeah. So if we have axial forces, so completely parallel to the implant, we'll have less problems completely.
So do you often use the surgical guide to place the implant with the right
I,
position or?
so that's the trick, and I didn't mention that
Oh,
in the lecture. Is I always use the surgical guide.
oh,
Even for the most simple cases, if I plan this ahead, if I'm able to place the implant on a computer and I know I want the implant in that position, then I'm going to be 100% sure, or at
yeah.
least 95% sure that I'm going to be placing the implant in the exact same position as I was planning. If I do it freehand, maybe I have a good day, maybe I don't have a good day, then you
Mm.
might not place the implant in the right position.
Mm. Okay. So next question. Question number 3. What role does digital occlusion analysis, like medical occlusion analyzer, play in implant occlusion? And do you recommend it over traditional occlusion marking techniques?
So I think technology nowadays it's developing really quickly. And you see with this program like Medical Occlusion Analyzer, where you can check how the bite is, where the problems might be. You can see the lateral forces, you can see any interferences, any tooth that's catching first. You'll be able to check that in a computer, and it's very visual. So the patient is really able to see it as well. So they're able to look at the computer with you, understanding exactly what's going on. But also as a diagnostic tool, we can see things that we're not able sometimes, because you need to see on a really back tooth with a mirror. Sometimes you cannot mark it with a traditional articulating paper. So I think computer nowadays it's developing really quickly, and there is some jaw tracking devices that they're out there with live recording of the jaw movement. We'll get there at some point where we probably won't need the articulated paper as much. But until now, I still, in my opinion, in my case, I still need to use the articulating paper, and I don't think we can just avoid using it. So we can use both at the same time.
Both. Mhm.
Yeah.
Okay, we are left with the last one. Question number 4. How do you manage occlusion in cases where the patient has mixed dentition? Some implants, some natural teeth, and possibly some partial dentures?
So as we said in the other question, we probably need to think about everything before we start. And if we know that the patient has already those conditions, then if the patient has done the implants and the dentures and the teeth and crowns in another practice, we probably need to think about reorganizing that occlusion. But the best case scenario normally is when you have a patient that doesn't have anything and needs a lot of work. So if we're going to do all those things, then we probably need to think about the final occlusion. The final occlusion is slightly different in natural teeth compared to implants or dentures. So we don't want implants to have more contact than teeth, maybe slightly less. And then dentures is a bit the same, because we have a bit of a movement of those dentures where implants don't move. So we cannot have an implant catching first, because you can end up with an occlusal overload. So we need to be really careful about those things. And if we're doing a complex case, maybe start with a simple one if we're going to be placing implant restorations. But if not, the rule is to have the implant in a slightly less occlusion than the rest of your mouth.
Okay, that was the last question. Thank you for answering all the questions.
You're welcome.
Okay, that's all about it for today. So thank you for preparing such a great lecture. Hope to see you next time.
Thank you.
See you next time. Bye bye.
Bye-bye.